PK, for the invitation, and
Thank
nice to
you
be
for
back in New
using
York.
the filter, Jose.
All right, so I'm going to start on anatomy. I feel like we almost should have started with this, but I have no financial stuff related to this. So I put some stuff on here. Just I know you can't really see it, but just if you go back and you look at the slides, just for reference. So there are a lot of anomalies, and this just shows the basic anatomy in the type 1A, where you have the typical, tibial trifurcation, and then some different variations. I'm going to show you angiographically, and here's some different, tibial takeoffs. So you see like sort of a true trifurcation on the left. Then you have the variation of a high anterior tibial takeoff in the second frame. The third frames are where you have a high sort of above the knee takeoff of the posterior tibial artery. And so again, if you go back to the last slide, you see different variations in that classification system. Down towards the ankle, you're going to have perineal arteries that supply, dominant perineal arteries that supply the dorsalis pedis on the left, one that supplies the posterior tibial, the common plantar artery on the right. I think we saw that in the first case today. And you can even see cases where you have single arch. So the perineal artery supplies the entire foot circulation. Again, just for reference, but really, you have the posterior tibial circulation, which is the medial lateral plantar vessels that give the digital vessels, and then the perforating or deep plantar artery that connects into the dorsal circulation into the dorsalis pedis. And then on the dorsal side, you have, not always, but a lot of times you have the lateral tarsal artery connecting with the arcuate and sort of like a loop that supplies the digital vessels from the dorsal aspect. And again, just for your reference here. So I think what's really important when you're doing these interventions is to take the right pictures. It may not be as important if you're doing a claudication, you just want to make sure there's no distal embolization, but if you're really doing something for critical limb ischemia, doing fine footwork, I always harp on, the right images. So you want to take sort of a lateral oblique shot here, separating the medial and lateral plantar arteries. You see the plantar arch, the way it looks in that view. It looks very different when you take it from a cranial view here. You can see it's like a figure 8. So again, just for reference, some of the names of the vessels. This is from Marco Manzi's paper, looking at the different views. And the peroneal artery has, a perforating branch and a lateral calcaneal branch. What I didn't put in this talk, which I should have, was the communicating artery. So again, if you go just a little bit higher, usually there's an anterior communicating artery and a posterior communicating artery, and it goes from the perineal artery into the posterior tibial and anterior tibial. So sometimes we use that to get into those if we want to use a transcollateral approach for intervention. And then again, more variants. So I haven't seen this in my practices, again, from Marco's paper, showing basically a lateral plantar artery that supplies the entire plantar arch. I have seen this, where there really isn't a dorsalis pedis or a very diminutive one, and the lateral tarsal artery is the dominant vessel that connects, in this case, to the medial plantar vessel. And then here, which I've not seen, but again, described in this paper, is basically the absence of a plantar arch, so entirely separate circulations, anterior and posterior tibial. So again, this is one of my examples of just the single, perineal supplying the entire foot. You can see our wire actually goes down through the dorsalis pedis, which is, again, minimal in this case. The lateral tarsal is more dominant. We angioplasty, and I think you can make it out sort of from this image, that lateral tarsal communication. See if we can go back one. So it's really pretty easy when you look at, patent vessels, what you're looking at and identifying anomalies. But the problem is that a lot of times you get patients who have these chronic total occlusions and you're trying to revascularize them. So I've been sent patients who've had failed AT intervention, for example. And then in the course of my intervention, I realized this doesn't seem right? The takeoff is a little funny. And so when I try to go from the posterior tibial into the anterior tibial, lo and behold, it goes into a dominant perineal artery. So again, always something to think about when you're doing these interventions. So this is basically below ankle disease, and you want to be able to visualize. So again, 4 frames per second minimum, stay on the pedal long time, a good amount of time to see the collaterals filling. You can see on the right side that loop of the plantar arch at the very end right there. So in your mind's eye, you have to sort of figure out where these vessels should run, where that plantar arch is. And it should come out to something like this based on your images. So, wires from both tibials. Here we use the cart technique to get back into the true lumen. And since this is more anatomy, I just want to show you the before and after. So again, good to see the digital branch is still there. Also, what's really important when you, and this is adding on Dr. Jenkins' lectures, super selective angiography. So not just popliteal injection. The left side is from a popliteal injection. But if you actually get an 018 support catheter down into the dorsalis pedis or into the common plantar or lateral plantar vessel, you can inject through that. And sometimes you see that the vessel is not actually occluded, it's just super small. So in this case, I have a CXC catheter 014 in the plantar arch, as you see those markers there. And we inject, and we basically put the pieces of the puzzle together to figure out where the plantar arch is. And in this case, that's what it looks like from the cranial view. You can see we balloon through the arch and the post images. So yeah, basically that was a review of the anatomy. Hope I didn't go too fast. And it's important to suspect the anomalies when you're having, cases not go the way you would expect.
Perfect.
Thanks.
Thank you, Dr.